Have you ever wondered what really goes on behind the scenes of government? How decisions are made that shape your community and your future? Welcome to Govern, the podcast where we take you inside the world of public service, leadership, and the innovation driving local change. Join us as we explore the roles of elected officials, how government operates, and what it takes to create real change. We'll dive into forward-thinking leadership lessons, and how we all can influence the decisions that shape our communities and futures. Thank you for tuning in to Govern with Supervisor Curt Hagman.
Hi, welcome to another episode of Govern. My name is Supervisor Curt Hagman. I represent the 4th District of San Bernardino County. And today my guest is Andrew Goldfrach, who's the CEO of Arrowhead Regional Hospital, which is a county hospital. That's the county hospital, right? And you've been named, a year ago, the CEO, and you've been doing a fantastic job for us. So thank you so much. First, why don't you introduce yourself? To me, you always look like a young CEO, but you were there and you've been running this operation.
I appreciate it and thank you very much for the opportunity. So as you mentioned, I'm the CEO for Arrowhead Regional Medical Center. And yes, we are the only public safety net hospital for the entire county and 20,000 square miles. I've been a hospital executive for about 20 years. I've been with the county for 5, the first 4 as the chief operating officer, and as you recall, a small stint as the public health director during COVID. But really, my career stems back all the way from where I came from, which is in New York, where I was an EMT growing up, following a horrific car accident from my father, which is what truly interested me in healthcare and healthcare leadership. And then I've kind of progressed my career throughout the country, having opportunities to work in the public sector, here, for-profit, not-for-profit, large academic medical centers, as well as, true community hospitals.
Well, Arrowhead has a great reputation. I know we do a lot there. We'll get into a little bit more of that. But for most of us, there are the difference between a private hospital, a public county hospital. What are the type of hospitals we have in this county?
So we've got 18 hospitals in San Bernardino County. You've got, we're the only public hospital. You also have a fair number of hospitals that are part of a large health systems. And then you have a couple that are independent hospitals. Most of the hospitals are either going to be not-for-profit private or for-profit private. We're the unique hospital that's the public not-for-profit hospital.
What does that mean?
So from a care perspective, it really doesn't mean a tremendous amount. We operate very much similar regardless of which status we have. The only difference is that we take care of all patients regardless of their ability to that. That's really been a fundamental steadfast for us, is that whether the individual is homeless or multimillionaire, it doesn't matter to us. We'll take care of every single patient with the same level of quality that you come to expect.
And it's a world-class hospital. I know we're not too long ago. Give you a chance to brag about our hospital.
Yeah, appreciate it. So ARMC is a 456-bed university-affiliated medical center, and that really helps stand us apart. We're what we call a tertiary care medical center, which is where we see the sickest of the sick. We are highly subspecialized in multiple services. So where a lot of the other hospitals in the county are more of a community-based hospital, the patients that they see there, if they need a high level of care, they actually send them to us to take care of those patients, which we're really happy about. One of the areas that we're very well known for is our critical care pulmonary care area. And in fact, we recently just received a national award called the Beacon Award at the highest level, which is a gold level for clinical care excellence. It's a national focus to really look at how clinical enterprise is really helping drive the operations and looking at our clinical outcomes and patient satisfaction. And we're one of a handful of hospitals in the state, even smaller in terms of national from a public standpoint, to receive that award.
Congratulations on that. And you talk about being a university hospital. I know we have partnerships with universities and medical schools. And how does that work?
So ARMC is a teaching hospital, right? We pride ourselves on not only being the hospital of first choice for our patients, but also as a teaching institution. And when you look at the evidence in terms of clinical outcomes, teaching hospitals tend to actually have much higher outcomes and much better outcomes than where sometimes people may think it could be the opposite, right? I don't want a student taking care of me. You actually see that when you look at evidence-based practice, teaching hospitals tend to have much higher quality.
We have 2 or 3 minds working on it versus one.
At least. And so we have 35 clinical school affiliations. Most of the schools are local in the area, where we bring medical students, we bring allied health professional students, we bring nursing students to Arrowhead to learn, where they could see and get an opportunity to work side by side with our clinicians on some of the patients that you wouldn't necessarily see at some of the smaller community hospitals. We also have a very strong partnership with a med school that's actually on our campus called California University of Science and Medicine, where we're their primary teaching hospital.
That's great. I'm very familiar with that partnership. I was one of the founding board members of the college, and I know that they're expanding. So not only do you have first class, world class healthcare, but you also have the research side going on the side of our campus, right?
Absolutely. And research is so important, especially from a teaching institution. When we look at how do we advance healthcare, how do we change the landscape, how do we drive better care and quality, a lot of that stems from research. And to not just take that research and then apply it, but to be part of actually advancing ourselves and saying, how can we do this better? And driving that research just makes us just that much better of an institution.
I'm going to talk a little bit about budget, just because we just passed our budget this recently for the county. It's a large budget. It goes to our hospital, but also it's a complicating thing being a public hospital because you have different funding streams. We get state, federal, local. If you have insurance, you get paid one way. Touch on that a little bit.
Yeah, we're very fortunate as a public hospital. We're actually one of a handful in the nation that does not rely on general fund. So our operations are what we call an enterprise fund, which is a part of the county budget that's actually a little bit outside of and doesn't rely on the taxpayer dollars. And like I said, I think we're one of about 5 to 7 hospitals in the nation as a public that are in that same camp. What that allows us to do is really focus on how we drive our strategies different. But from a budgetary standpoint, about 50% of our revenue comes in from what we call direct patient care. So from our insurance providers, IEHP, Medicare, Medi-Cal, commercial payers. The rest of that funding streams comes in from multiple different sources through what we call value-based programs. So initiatives either at the federal, state, or local levels that align quality to reimbursement, which I really think is actually a great way for us to continue to promote our quality initiatives. Is if we're not doing the right thing, we're not hitting the right quality measures, we don't get reimbursed for it. But it does also force us to really rely heavily on those. It costs a lot of money to run the hospital. As you mentioned, we're a very complex organization where I almost look at us as a mini city. We've got 5,000 employees at Arrowhead. We've got 1.2 million square feet on the main campus, but we've got 6 campuses with some of our offsite locations. So it's a big, very complex enterprise that costs a lot, and we need to be able to generate those revenues back. We don't, unlike some of the other for-profit entities, those revenues don't go back to shareholders. They go right back into reinvesting in our employees, reinvesting into our infrastructure to continue to advance our mission of healthcare.
So we're kind of like a nonprofit on steroids.
Very much, sir.
Okay.
Very much.
And I know we've been adding things to the campus a little bit. Can you talk about the today and the future, what we're working on?
Yeah, one of the things that we're really focusing on is continuing to add and expand access to care. We've historically had about 5 primary care clinics, 4 of them offsite, 1 on campus. And we're really looking to continue to grow and expand that, provide more care local to where patients live. That allows us to do a couple of different things. One, continue to grow care as the population in San Bernardino continues to grow. But it also allows us to decompress the main campus. We're at a point where the medical center, when it was built, had a census of about 130 patients. Today, we have a consistent census of over 400. And if I were to build a 600 bed, we fill a 600 bed. But we're constantly bringing new services to Arrowhead. Recently, we partnered with a new group for our cardiology and cardiothoracic programs, and we've just hit the ball running with our cardiac programs. We're similar with our vascular programs. We actually had one of the busiest vascular surgery programs in the entire Inland Empire, and one of the busiest orthopedic trauma programs in the entire state. And by continue to advance medicine, bringing in some world-class physicians, world-class talent, we're attracting more and more patients to ARMC.
And it was interesting for me to know a little bit about it was the doctors are not necessarily our employees. They're
Correct.
doctors groups that we contract out, correct?
Correct. So we have 26 groups that make up our medical staff of about 500 physicians. That does not include our residents. And they're all independent groups. And in fact, in the state of California, it's illegal for hospitals to actually employ physicians, which allows us to better partner with them in what we kind of call almost an entrepreneurial model, where we'll contract every 3 years with the different practices and align our strategic initiatives with them. And then they get paid either by us and also by through direct payment that are tied to those strategic initiatives.
Is there anything on your wish list that you don't have yet at your hospital?
A lot. The laundry list is long. But I'll tell you one of the things I'm very proud of is actually yesterday we just broke ground on a brand new hybrid operating suite, which will be innovative and state of the art. It's a project that we've been trying to get off the ground for several years. This will allow us to really advance our neurosurgery program as well as our vascular program. It's what's called a biplane hybrid OR. So it really infuses both bidirectional X-ray at the exact same time as being able to do both minimally invasive and open surgery in the same environment, which really reduces the amount of time the patient to be in the OR and increases patient outcomes. And we're one of a handful of hospitals in the state that will have this capability, including, especially when you look at what's out there, UCLA, Cedars, and all the big hospitals don't have this capability.
Now, I know we're going through a time period and I like innovation, and I know that our current ambulance service and potential future providers in the area, it's always been a question is where do you take someone when you go pick them up? Because generally they only get paid if they take them to the emergency room.
Correct.
Where we always had this policy debate, well, that not every person needs to go to the emergency room, and to make it better services or quicker services, more efficient services when it comes to the budget when they go to their clinics and other things. And our counties being geographically as large as it is, being the largest geographical county in the United States, these clinics become now more important. So tell me about how you see the policies may or may not be changing, especially with alternative care locations for people to get service. How does that fit into the bigger model of Arrowhead and its clinics?
So you're correct in the sense that currently under current law, ambulances can only direct patients once they're involved to an emergency room, and they can't go to an urgent care or other settings. Most of the country outside of California allow for freestanding emergency departments. California currently is illegal for hospitals to build out freestanding ERs. It is being introduced at the state assembly level at this point to look at that. That would go a long way for us to be able to build out, freestanding emergency room in some of the more remote areas where economically it doesn't make sense to build a full-fledged hospital, but allow to get quicker care to the patients a little bit closer to home. The other thing that we've invested heavily on as a region is our critical care air transport services. They're phenomenal, right? I know we've got a fair number of helicopter services between Reach and Air Methods and Mercy Air and our sheriffs. And they're great because they could take a patient that would have been a 45-minute drive, 10 minutes to a trauma center.
Yeah, there's an accident 15 near Vegas and they have to come to the county hospital. That's quite a drive.
That's quite a drive. But if you fly in, that's a 20, 30 minute while they're already starting to provide critical care services in the helicopter and then get them down to the trauma center. And just to expand that a little bit further, not only are we one of the two level 1 trauma centers in the county, we're also the only burn center for not only San Bernardino County, but also Riverside County, Mono County, and Inyo County.
Wow.
So if you've got a burn all the way up in Mono or Inyo County, they're flying directly down to us.
That's amazing. So I'm considering all the different boards. As you know, I sit on Inland Empire Health Plan, which is our public health care safety net for San Bernardino Riverside. And we see a lot of changes on the horizon, especially we get our funding from the federal government for the most part. State government pitches in on certain places as well, but they're making a lot of changes. How do you see the budget forecast? It's going to be a lot of changes. And for us, as we lose members that may not qualify now under the proposed budget, that means the county is going to have to pick up, the county emergency room probably pick up those numbers.
Correct. So if I had a crystal ball to help figure out what's going on the federal or the state level, I'd be using it. We've heard a lot of different scenarios, as we know. At least as we sit today, the House has passed their version. The Senate's in debate as to what that's going to look like. So at the end of the day, we're still not 100% sure, but we do know there's going to be significant impacts. We know that there's going to be impacts on the state share of the federal, the state share of Medicaid, or in California, Medicare. As the county entity, we actually pay the state share. The state does not. So that'll be an increase of expense to Arrowhead. But we're also seeing a potential decrease in the amount of enrolled members in Medicaid based off of a variety of different factors. Those factors are still being worked out. It's hard for us to predict exactly where we're going to land. But you're right. So one of the opportunities that the health plans had is if they lose members, they change their strategy. They work through what does that look like, and they move their business model accordingly. As the healthcare provider, I still see those same patients. I just don't get reimbursed for it.
Yeah.
So we're really understanding what those impacts are, looking at some of those models that might have to change from a business standpoint at ARMC. It's something that we've lived through before. So this is very reminiscent of the Affordable Care Act, where we were seeing 130 to 140,000 patients in our emergency room. Right now we're about 90,000. I expect that to go back up. I expect us to be looked at a little bit more as a primary care site for emergencies, so
That's why I wonder how the clinics may. If you have a site clinic and clinics throughout the county, should we be directing people there if it's not an emergency?
depending on the type of clinic, but yes. And that's part of where our strategy is to also say, when we look at access, is to how do we create more access in the community, create more of an ambulatory strategy to really decompress the need for patients to come to the main medical center.
I remember some of the nightmares we had during COVID, ambulances being backed up, just the sheer volume that you had to deal with back then, that you're looking at other strategies to provide services for our residents. And, candidly speaking to a lot of my hospital owner friends, there's a good percentage of people rolling through emergency room that never need to go to the emergency room.
100% correct.
And so if we could figure out that alternative way for them to get service and get care, because the emergency room is probably the most expensive doctor visit you could have versus a clinic or urgent care or anything like that. And so we need to have that education out to the residents. Here's some of the options. It's still, if you're not coverage, we're still going to cover you, but for these type of things. Another big one we've had since COVID, which I applaud, was telemedicine, and that kind of whole new pathway. How does that work with the hospital? I know the doctors have now got approval to charge something for that visit, but how does that work for
the hospital? Doctors have the approval, but the state and the federal government are not paying what's called the facility fee, or our side of that. Mm-hmm. So we could pay the physicians, but not necessarily the hospital. We still do telehealth services, primarily in our primary care setting, as well as our correctional setting. So where we could keep inmates in the jail, I'd rather keep them in the jail versus bring them to the hospital. So we focus a lot on telehealth there. We focus a lot on our primary care initiatives and primary care visits. So that way patients in Needles or Ontario or wherever don't need to drive all the way to the medical center for their primary care services. But we're constantly looking at how do we evolve and build technology and AI into our environment to reduce the amount of travel time or need to come in. One of the areas I'm very excited about that you'll approve at our next board meeting is a contract with Microsoft, where we're bringing a contract to do ambient dictation in all of our clinics. So that way, as a provider and patient, we could just have a conversation. And AI is listening to that conversation and then drafting the physician.
You guys will ruin the reputation of the doctors and not be able to read their scribbles anymore. So what you do that, you're actually be able to read what they say.
You'll be able to read what they say, and they'll be able to appropriately document time. Right now, a lot of our physicians, one of the biggest reasons for their burnout is the amount of time that they need to spend after the visit on documentation. So physicians nationally tend to do one of two things. They'll have a conversation with you, right? And then later on at night, actually Epic has a word for this, they call it pajama time, right? They will document the note. But there's a good chance that they may miss a key aspect of our conversation, especially if they see 20, 30 patients a day or more, and then now they're getting documented, there's a chance they may miss something. Or even worse, they'll be sitting in front of the computer in the exam room, just staring at the computer screen typing and talking to you, but not really engaging with you. Now they could have a conversation. The technology will listen to it. They will draft the note based off of what's important for medical billing purposes. Then the physician just has to read it, review it. They can edit as they want to, approve it, and then move on.
Sounds great. So technology is coming in, and as we see that with our, always had a nurse's hotline, but now this telemedicine and other things that we could be able to reach in the areas. I know that we're having difficulties with some of our remote areas, always to have the right specialties, especially specialties up in areas that doesn't have a lot of population. It's hard to put someone with the school for 10, 12 years and go up there and try to do a practice when there's a population that's pretty small. So those are the ones that have to travel quite a bit. And sometimes because of the travel, they don't get their checkups and don't get their visits and their treatment like they should because they just can't make it to certain areas. So all this is fascinating to me as we integrate our emergency services, part of that as well in conjunction with Arrowhead. I know you set all the right committees to oversee that as well and kind of give us direction. So thank you for all that service to our residents.
Thank you.
It took me over a decade being in office now to kind of understand there's everything from prescriptions to partnerships we have and this.
Arrowhead is not your typical county hospital. I'm really proud to say that we are a true tertiary care medical center, university affiliated, that takes care of every single individual. We are one of the largest hospitals in the county. We've got some of the busiest services in vascular programs, a very strong women's health program, pediatrics, cardiology, neurosurgery, neuroscience. We're also a major teaching hospital with 17 accredited residency and fellowship programs. What I love about us as a public is that actually there's only 17 public hospital systems in the entire state of California. Yet we represent over 50% of all the medical education that comes out of the state of California. And just to be part of that and to be helping drive the next generation of clinicians is some very
Once we keep here with
and hopefully here, which we do a nice job with that.
Well, thank you so much for joining us and give us a little bit of insight into what goes on to the county hospital. Appreciate everything you guys are doing over there. And we have great men and women serving our residents. Absolutely. So appreciate that. And thank you all for joining us in this episode of Govern. Please stay tuned for the next one coming up.
We hope you enjoyed the conversation and found some valuable insights. Be sure to subscribe and stay tuned for our next episode. Until then, remember that your voice matters in government.